Hi, for those of you who don't know me, my name is Jeff Greenfield, and I'm a professor of neurosurgery at Weill Cornell. And I've worked with Chiari Project before, and have gotten to know Ashley and Jared quite well. And it's our pleasure to be here again with some other invited guests who I'll get to in a moment. Um, Jared approached me about trying to create a webinar that was focused really on the specific aspect of pain management in Chiari malformation, and that's really a central topic for every facet of how we take care of patients with Chiari. And when he asked me to do this, I thought that there was almost no way I could do this without having the rest of the partners in the hospital share this with me, because really this is so multifaceted. And so by way of introduction on this slide that I have up here, I'm at the top only because it's sort of the patients come to see me in the office, and we talk about the symptoms that they have. And pain is obviously a huge part of Chiari, that is in the form of headaches, neck pain, pain in their extremities, numbness and tingling. Those are all pain symptoms. But when we get to the point where we're talking about surgery, we're also then shifting into the question of what is the pain of surgery like? So you've got the existing pain of the condition, and then you've got worry and anxiety about what the pain of the surgery will actually impart upon them. And that's often really disabling for patients. And many patients, avoid surgery for years and years because of those fears and anxiety. So hopefully we can talk about both of those things. And then by way of, going around the circle here, once the patients actually make the decision with me and Amanda to, go forward with surgery, a big part of, making them feel comfortable is knowing that we've got a specific protocol and a really professional team that has taken care of literally probably over 1,000 Chiari patients in the operating room. That's led by Maria Bustillo, who's been so kind to join us tonight. She's the director of neuroanesthesia, and hopefully can share some words on what she's seen as the evolution of our management of these patients in the operating room, and how this has affected their transition from the OR to the intensive care. And then seamlessly, Beth Higgins, our senior physician assistant in the hospital, will then pick up from that point on as the patients leave the intensive care, and then begin really maybe their most important part of the pain management journey, which is getting through the surgical portion of their pain and figuring out how to manage all the different options that exist, how to deal with getting ready for discharge and the anxiety of taking over that pain management themselves once they go home. And then finally segueing back into Amanda, who started the process with me in the office. Amanda is our PA in the office, the director of the Chiari Care program. And she gets the handoff, calls the patients the next day, and carries the baton forward until about 30 days post-op, what point, if there are still pain-related issues, it usually goes back to a pain management expert or PCP. So all people on this screen are incredibly important at different points. And I think everyone's point of view is really important here as this has evolved over the years. So I'm really thankful for each one of you for joining us today. And I think that's a great introduction to sort of the team that takes care of our patients here at Weill Cornell.
Absolutely, that's fabulous to have everyone here. I think we could probably get started with everyone maybe sharing a little bit about their perspective within the team. Either something that maybe drew you to this line of care, something you enjoy working with patients with Chiari malformation, and just kind of the way that you tend to approach your patients. I'll kind of leave it open-ended for whoever wants to start.
Amanda, why don't you start that, since you're the director of the program and you're the one who spends the most time talking to our patients and listens to what they've got going on in their lives. What is it about this job that keeps you motivated?
Hi, my name's Amanda. I've been with the Chiari Care now for a little over 2.5 years, and I think what keeps me drawn to this program is that it's very niche. I think that these patients are very much misunderstood and misheard, and it's very validating to be able to create a comfort and a bond with a patient, for them to trust you and know that you can really help them. We're pretty conservative in our approach, so we do want patients to have tried medications and other therapies before considering surgery. And so by the time the patients get to us, they're pretty run down, and they really just need a friend and a helping hand to get through the process. And the patients are very grateful, very appreciative, and it's very rewarding to work with them and know that you are creating an impact on someone who has felt, not heard for some many, many years, decades even.
Beth, do you want to go next?
Hello, I'm one of the
Oh,
inpatient.
go ahead.
Oh, sorry. Hard to manage these Zooms. Go ahead, Beth. Thanks.
Sorry, Dr. Bustia. Thanks, Dr. Greenfield. So yes, I'm one of the inpatient PAs. I've been here, like Dr. Greenfield said, quite a while, since he was, I think, chief resident. And similar to what Amanda said, I feel many of our Chiari patients, they have had a kind of a vagary of symptoms, if you will, for years or decades that people haven't been able to piece together. And they're very frustrated. They feel unheard. They feel people think they're making it up even potentially, and that's a very, very frustrating place to be. So by the time they reach us, they've had a rough road. So we really work to try and improve upon that. No one wants to be in the hospital. Nobody wants to have surgery, but we're happy to be part of the care if that is the best choice for you based on the workup with Dr. Greenfield and Amanda. And we have a large team of PAs in the hospital and neurosurgery residents. So we all work together with this ERAS protocol. ERAS is enhanced recovery after surgery, but it includes pre-op care, including medications and how long your NPO, like you can't eat or drink, really trying to minimize the discomfort and really improve the recovery. And neuroanesthesia team really kind of were the leading force under Dr. Bustillo to incorporate this into the pre-op, intra-op, post-op, and discharge care. So I think just making that difference and having people feel heard. And we may do this very often, but I always tell our team, like, it's this person's one body, one head, one back, one neck. So we have to remember that just because we may have had 5 patients with the same thing that week, for this person, it's their one life. So we have to be very cognizant of that.
Thank you. Dr. Bustillo, we've cut you off twice now. Sorry.
That's okay. Hello again, I'm Maria Bustillo, and thank you for including me on this talk. And when we started to work on the enhanced recovery after surgery protocols, we started to look at pain in multiple dimensions. It's not only one kind of drug that is going to work. We use multiple kinds of drugs or medications to help ease the pain. And we start from the preoperative time, and we continue into the intraoperative time and then in postoperative time, in a way that there is a continuation. There is no clashing of medications. There are not side effects associated with them, because we are using them in a way where we don't use a lot of doses of only one drug, but doses that are going to work together to improve the pain of the patient. So that was our approach from the beginning. We also look at hydration. Our patients, unless there is any reason why they drink fluids until 3 hours before surgery, which has shown to improve the overall status of the patient preoperatively and postoperatively. And we also watch closely hydration, positioning during the procedure. All those things are important in these for these surgeries. And we communicate clearly with our ICU colleagues when we transport these patients to the ICU, what medications they got, what medications they received, so they are clear on how they should continue their treatment.
Yeah, I could add one thing to that, which is that I could have probably invited someone from the ICU as well. The intensive care unit is usually the first 24 hours after surgery. The truth of the matter is, over the past couple of years, the pain management in the operating room has gotten so good that they're essentially just hanging out in the ICU that first night because they are incredibly comfortable waking up from surgery. And it's actually usually the post-op day 1 and 2 where they start experiencing more pain after Dr. Bustillo's cocktail has worn off. So the intensive care unit used to be a primary zone for, really initiating the pain management. I think it's actually shifted now, onto Beth's team a little bit more. I don't know if you feel like that's the case, Beth, but I think the OR protocol has dramatically changed the experience of our patients to the degree that I think we've cut more than a day off of the length of stay, and probably a day and a half if we look at the data over the last 10 years, from where it used to be 4 or 5 days for the surgery, quite an extensive and often painful surgery, to the point now where patients are frequently leaving on the second post-operative day now, which, again, I mean, I'd like Beth to weigh in on this, but I think it's been a dramatic shift in their experience and their overall perception of how difficult the surgery was to recover from. But I think it starts pre-op, it continues through the OR, and then it really reflects on the transition between the different teams from OR to ICU to the floor team.
Yeah, I would definitely agree on that. I feel we've become less reactive and more proactive. I think we were chasing pain in the past, where now we are instituting the ERAS, this enhanced recovery after surgery protocol, in advance. And that really does help with pain. I think also expectation, 0 pain after surgery is not realistic. So having that communication that there will be some, we will do our best to control it. Like Dr. Bustillo said, it's kind of a multi-prong approach, looking to reduce narcotics, hopefully, but using other medications, other classes in addition to narcotics. Really, we have a protocol, but we also still step back and look at the individual, because there are times you have to deviate slightly, which I think is also important to acknowledge. And also look at home meds. Sometimes, we make some changes based on that to minimize polypharmacy, so multiple different classes of medications on discharge, adding things to home meds. Sometimes we have to make a compromise and do another class so that we're not putting too many sedating medications on people leave. But I think we've become much more proactive, less reactive, which has resulted in less time in the hospital, which ultimately is usually better for everybody involved.
And Amanda, maybe you could finish the loop here, since we're doing this sort of little cycle here. Getting the patients on the phone the day after surgery, have you noticed any shifts in their, self-reporting of pain, their use of narcotics, the length of time that they require that? Keeping the outliers aside, the majority of our patients, what's been your experience, honestly, when you call them post-op day 1 or post-discharge day 1?
Yeah, I mean, I think just to take a quick step back, I've been a neurosurgery PA for 10 years, and I have to agree, I've seen Chiari surgeries at other institutions, and Weill Cornell New York Presbyterian really does have a solid pain program. The patients get out much quicker than I've seen historically, which makes my job easier when I call the patients the day after discharge to check in and see how they're doing. For the most part, they're doing well. I'd say that prior to discharge, it's important to make sure that they're tolerating PO pain medications, and that plan is working for them. So when I call and check in, sometimes it's just tweaking how often they take it, or maybe increasing a muscle relaxer at night to make them a little bit more comfortable for sleep. But ultimately, I'd say the inpatient team does a really good job at passing the baton to me, as opposed to me needing to reinvent the wheel, which is really nice. And also, I think, to sort of be full circle, when I meet with the patients, we go from soup to nuts and go over their past medical history and their medications. And that's really important, right? It sounds silly. That's what we should be doing before a patient goes into surgery. But I really need to know the patient's background, right? Do you have an autoimmune disorder or rheumatologic disorder where I'm going to need you to stop some of the autoimmune medications? That means that they may have a flare-up after surgery. And so we need to create a plan, whether it's with me and their primary care doctor or the rheumatologist, on how their other pathologies are going to be managed when they're off of those very necessary medications. looking at their pre-op pain medications, right? So as Beth said, how do we incorporate that to minimize polypharmacy, but also knowing that they're going to probably change and or increase if you were managed with narcotics and muscle relaxers, migraine medications before surgery, knowing that we're doing some authorizations with surgery, right? That's the goal, and how to manage that. Also making sure we have a lot of out-of-state patients. And so for me to prescribe narcotics over state lines has proven difficult. So making sure that the patient has a pain plan even prior to getting to New York City for surgery, right? Making sure that the patient has their primary care provider on board or their neurologist or their pain management provider to really take over once they return home. I do see the patients with Dr. Greenfield. We clear the patients to travel home, and I do make sure that they have at least 2 weeks of pain medication to get them through if they need for their next appointment. But creating a pre-op plan, really preparing the patients for what to expect after surgery, I think, and I hope, has been really helpful to manage expectations when they're in the hospital. And I've had lots of patients tell me, you know, you really told me there was going to be a whole lot of pain, and that wasn't the case. And I love to hear that because I'd rather give patients realistic expectations than sugarcoat what's going to happen and have them not be prepared. Of course, honesty is the best policy, at least for me. And so I find that when patients really understand what the process will be like, they can take control and they're more proactive, which is really nice.
I just love the way that I think a lot of things jump out at me, honestly, about the way that you'll approach patients in this way. And so I'm also speaking not only as a, representative of the organization here, but as a patient and someone that had gone through this surgery. So a lot of what y'all are saying and the directions that we're moving is definitely ringing, it's hitting really deep with me. And I'm sure a lot of people listening will relate to the experience. Unless y'all had planned differently, I think something that might be helpful is if we kind of keeping on this kind of loop design that we've got here, walking us through some of the discussions and some of the strategies in our pre-op, intra-op, and post-op, kind of phases. So maybe starting with the clinic, considering a patient who is either hesitant about surgery or questioning surgery, what are some of the things that maybe we're trying and we have to fail before we consider surgery? How are we roping in things like physical therapy or non-prescriptive measures? I just kind of love to open it maybe with an outpatient setting first, leading into surgery, if anyone wants to kind of go with that.
Yeah, sure, I can take over. Yeah, absolutely. So Chiari patient symptoms can very much range. I mean, the most common is headaches, neck pain, pain in the back of the head, but they can also have numbness and tingling in the arms, the hands, the feet, bladder bowel changes, sleep apnea, difficulty with swallowing. So the workup is really individualized for those patients, and I'd say that conservative measures will really depend on their symptoms. But ultimately, before they come to me, I want to make sure that they have tried something, right? So if swallowing is their concern, we get a swallow study if they haven't come with one, or if their chief complaint are headaches, I want you to have seen a neurologist to at least trial headache medications so we can really rule out that it's Chiari headaches and not migraines. Same with numbness, tingling in the arms, right? Is that from a cervical spine disease as opposed to Chiari? So really ruling in that this is Chiari and that it's not anything else. And of course, there are overlapping pathologies, but trying to identify what we're going to help to set realistic expectations post-op. And also letting patients know that I can't promise you you're going to go back to, age 5, maybe when you didn't have symptoms. And not to, we certainly have a lot of peds patients 5 above and below who have symptoms. So maybe that wasn't a fair age, but really trying to isolate what the symptoms are so we can tell them what we think will get better and maybe what will stay the same, maybe what's not related to Chiari. Same with physical therapy. I wouldn't necessarily prescribe physical therapy or expect a patient to come in having tried physical therapy if their chief complaint is incontinence or if it is headaches, right? So really tailoring the plan to the patient and their symptoms. looking at them at a whole to make sure that we're not prolonging a potential surgical journey, but making sure that we have crossed our T's and dotted our I's to make sure that surgery is the right decision, because ultimately it is brain surgery and it is a big decision.
Yeah, the part that I'll echo from Amanda's, excellent introduction there is that Chiari is often used as a name for an MRI scan finding. And in reality, Chiari is many, many different conditions. And the way we look at, a Chiari patient at Weill Cornell may be different than other places with respect to, how we triage them and how we put surgery into their treatment plan. Surgery is always the last resort, except in a very few circumstances where there are really obvious, objective findings on exams, like Amanda mentioned, like central sleep apnea from brainstem compression, or dysphagia where patients are aspirating actively, or a scoliosis that's, worsened dramatically in a short period of time. Those are all objective measures that we can, look at and decide upon and make recommendations for surgery. Most of the patients, however, actually fall into the subjective category, where they're coming to us with symptoms that only they experience, and that might be dizziness or ringing in their ears that's debilitating, that we can't assess on an exam. It might be pain that they perceive in a different way as being detrimental to their quality of life than we perceive in a 30-minute office visit. So it usually, it's the rare patient where they come to the office and we actually talk about surgery on the first visit. And so that makes this kind of a unique field. But pain is central to almost everyone's conversation in one way or another. So to get back to the topic of pain, headaches are probably present in about 80 to 90% of our patients to some degree. Some patients can live with it and it's not debilitating. It's just that sharp kind of tussive headache that goes away after 3 or 4 seconds. And some people live with chronic pain that we really need to sort out. And those are the patients that need neurology and pain management, because it's highly likely that surgery is not going to eradicate the pain. And that's echoing what Amanda said. Success and pain management, it's not something that we have great outcome measures on that everyone agrees upon. My favorite outcome measure is, are you happy that you had the surgery? Would you do it again? Do you think it's made a difference in your quality of life? Those are the things that really resonate. And, the same exact surgery can, improve someone's pain 50%, and they could be ecstatic with that after having failed therapies for years. And some other people may feel, disappointed in that outcome, that they've only improved 50%. And so the best we can do is, create realistic expectations, create a really comprehensive preoperative plan to make sure we haven't missed anything, and then involve all the experts here on the screen so that we, give them the experience that can maximize their recovery and give them the best chance of that outcome.
I think thank you so much for clarifying. I think that's fabulous. I think something that might be helpful, I see this a lot when I interface with other patients with Chiari, is I see a lot of people, I think, express frustration of, I'm trying to explain my symptoms, I'm trying to explain my pain, and they're just not getting it, or they're just not listening. And I think that also goes with us as clinicians too, of how do we phrase these questions so patients can verbalize their things in a way that make sense. So I think to both of you, is there a way that you're phrasing questions that we can learn from, that we can ask in a more enlightened way to help patients really explain, and vice versa? How can patients help you kind of be inside their skin a little bit and understand their experience better?
Yeah, I think it's a two-way street there. I mean, to say the patients need to explain themselves better is a little unfair. I think the questions that I use in the office that often get to the heart of the matter as to whether or not they're going to, be great candidates for surgery or not, is typically revolves around this idea as to whether or not the symptoms collectively are affecting their quality of life. And it's a very vague term, but usually when you qualify it within the setting of, okay, you've got a 9-year-old child, are we talking about headaches that land them in the nurse's office, 2 or 3 days a week? Are we talking about they've decided that they don't want to do soccer anymore because it hurts every time? Are they not going to play dates? Those are very different metrics than for an adult, who you may say, well, are you missing work? Have you stopped going out with your friends? Are you now taking headache medication on a daily basis. Like whatever those metrics may be, they're different for every person. And I think once you drill down into, are you living the life that you want to be living? Is this affecting you on a daily basis on a way that you feel like you could be living at a higher level on the adult side, and then advocating for children if it's the parent? That usually gets to the heart of the matter as to, whether or not they're right candidates. If it's someone who is managing things decently and, is, living their life with 90%, then usually we all agree pretty clearly that surgery is not right. And very, very rarely is there a circumstance in which Amanda and I don't agree with the family or the patient as to the right time. It's usually self-evident that this is the visit where we're starting to hear a change in the tone. This is becoming debilitating. This is now affecting more than it was 6 months ago. And so having that long-term relationship with the patient and having met them multiple times and followed them over years is really helpful. I just operated on a boy this morning who I didn't realize I'd seen for the first time in 2016. And so seeing a patient for 7 years and, every couple of years saying, nope, not yet, nope, not yet. And then having the family say, we're there. That's really reassuring when it's a complex situation and child has communication issues and you're really relying on that trust and that communication. And so there is no single metric that we can use. And that's frustrating for Chiari. It's frustrating for the community, for research, for advocates. But I think if you get to, a center that sees a lot of patients, I think this becomes intuitive in a way that's just hard to express. Hopefully I've done it a little bit. I don't know if Amanda can, elaborate at all on that, but I think we share the same philosophy in the office.
Yeah, I agree. I mean, I think to go back to Ashley's original question, just to be a little bit more granular, I always try to localize where the pains are. And for the most part, even for kids, they're able to point, I have pain here, or I have pain here. And then I'll always try to use different terms. I'll throw out different terms like, does it feel like ants crawling on you? Does it feel like pressure? And most of the time, if I give out different adjectives, patients can pick what it feels like. And then I always leave it open-ended, or saying, does it not fall into any of those, or is it difficult to explain? And I think that gives them the comfort that I'm not frustrated that they don't fall into a specific category, because they've been for so long trying to fit into something that just doesn't quite fit, right? And that goes back to them not being heard. And so validating all of their symptoms, even if I don't quite understand them. And then going back to what Dr. Greenfield said, ultimately, does this affect your quality of life? I don't necessarily need to understand every symptom, but I need to know that it's significantly affecting you and that you're ready. And kids maybe have a little bit more of a hard time verbalizing, but their parents can see, oh, I can see that grimace, or they're sitting out of recess, or they're just not the same as they were with their siblings. And so it gives us, good insight into the patients that really can't advocate for themselves.
Yeah, I think, no, that's a really great way to put it, of kind of using some of the language, and sometimes it's helpful to give people the words, and exactly like you're right, sometimes they need to be open-ended and just to express how they maybe don't fit in a box that other people, before they reach to someone like at your kind of center, is trying to force them into a certain box or things that way. So I think the way that you're approaching allowing the patients to really clue you in and speak to a receptive provider is really amazing. I think personally I'd love to hear a little bit from Beth and Dr. Bastillo to rope in a little bit more of the inpatient, perioperative, post-operative phase of this, where what's some of the way that we're interacting with inpatient patients? When do we need to adjust our more routine pain management plan? What's some of the counseling we're going into about expectations of pain? I'd love y'all just to weigh in.
Yeah. So, well, from the anesthesiology point of view, we'll evaluate the patient from every point, not only pain. We are going to look at everything. We are going to look at pain in the neck area, how much they can extend or flex their neck, because that affects how we do part of our anesthetic. We're going to look at all the medications that the patient is taking, not only pain medications, but if the patients are taking anxiolytics or any other kind of medications that can affect not only their pain part, but they can interact with the anesthetic part of things. So we are going to look at all these things preoperatively, plus any other conditions that they could have in addition to their Chiari. So we look at the patient as a whole. And then in the operating room, again, we look at positioning of the neck, positioning of the arms. We want to be sure all the pressure points when they are going to be in the same position for a few hours during surgery. So the surgeons and us together, we work to be sure that everything is well padded, well positioned, so the patient doesn't wake up with an additional pain or any other problem. We look closer to their pain medication. We adjust pain medication accordingly to what the patient was taking before surgery. Some patients come, they were not taking pain medications. Before surgery, their requirements are a little different than patients that come that they were already taking pain medications before surgery. So we have to adapt to that as well. As I said before, we look at all hydration and everything else that the patient requires during the procedure.
Dr. Bustillo, can I ask you your opinion now that you've seen, hundreds of these? We have a very high percentage of our patients that have connective tissue disorders, Ehlers-Danlos, and many of them do seem to perceive pain differently. They have different thresholds. They have different peripheral nerve issues, and they probably metabolize differently as well. Have you noticed that or taken that? Do you take that into account at all, or do you adjust that just based on how they seem to be responding physiologically during surgery?
No, we take into consideration what they report to us, definitely. We take into consideration if there is any particular position that they report as being worse for them than not. And we take into consideration if they're taking pain medication before, because they will definitely have a higher requirement intraoperatively and postoperatively. So the dose for a particular patient like that is not going to be the same than the simple Chiari that doesn't have, and I don't want to say simple as undermining, but the patient with Chiari that doesn't have any other issues associated with it. Sure. So definitely the requirements are going to be higher, and that, yes, you see it. You see some patients react differently intraoperatively than others.
Beth, do you want to share your perspective on the postoperative perspective? Same idea here in terms of how you make adjustments, on a case-by-case basis. And I'd also love to hear your perspective if you have any experience or, observations on how our EDS patients might be different with respect to their thresholds or their narcotic requirements. It just seems to be, a recurrent, theme in our patient population that they do split off into these two camps that have slightly different requirements, and maybe we should have slightly different expectations. Do you see that?
I don't know that I've noticed particular differences, to be honest, and that might be because it's already been addressed and the intraoperative cocktail by Dr. Bustillo and her team has already accounted for that. I do feel being part of the intraop team as well, and first assisting in surgery, either one of the PAs or the resident, that really helps me to understand the postoperative care. I think before I was involved in the surgical procedure, you can read about it, you can watch videos, but until you're in the operating room with you doing these cases, it really impacts your appreciation for the complexity of the surgery and the musculature involved. And it helps us, the intraop and post-op team, because most of the postoperative team has been in the OR, it really helps us relate to the patient's experience. I think another important thing is it's not just medications. ERAS is, like Dr. Bustillo mentioned, it's hydration, but it's early mobility. It's getting the Foley catheter out so people can move, getting them detethered, if you will, removing lines that are no longer medically necessary to really help people mobilize and help prepare them for that next step. Because ultimately, when you arrive at the hospital, you're thinking about when are you going to go? When are you going to leave the hospital? So really helping people get to that point as soon as they can, because being out of the hospital is the best part of recovery. You don't recover in the hospital. You have your surgery, we do your post-op care, but recovery really begins when you leave. So I think helping people get to that point where they're comfortable and their families are comfortable. A lot of time people are a little bit resistant or, uncertain. And I like to ask, well, what is your concern? It is a big step, but it is a good thing that we feel you're ready for that. We would keep you if we thought medically it was necessary. So I think just having that conversation, feeling heard, helps people. And sometimes concerns are things we're not aware of, a home situation or a mobility or a 10th floor walk up, things that, it does impact how we approach patients. Our physical and occupational therapy teams typically see all of our Chiari patients, and they're fantastic as an evaluation service, also helping give tools that help people when they leave the hospital. And I think also I know for me personally, I'm known as a bit of a stickler for looking at every little piece of everything and very attentive to detail. So really delving into the chart, what are some of those medications from pre-op that we want to maybe reconsider reaching out to Dr. Greenfield saying, hey, I noticed this, I think we can maybe make a change. We do have our protocol, but we are clinicians who take each patient into account and make changes based on that. It's not a robotic type of protocol by any means. And really, I think, mobilizing and getting people, moving forward in their care is one of the big things. So.
Are there, you touched on it a little bit, are there certain metrics, for example, that a patient needs to kind of be demonstrating XYZ before we're considering discharge?
So they're not hard and fast. Again, each patient is that little bit different. They need to be tolerating oral medications. That's a big thing. Often patients are on a pain pump, so they're pressing, it's called a PCA or patient-controlled analgesia. They need to not be using that very much anymore so that we can transition them to oral, because you cannot go home on IV pain medications. Again, zero pain is not realistic. There will be some. I mean, if there's zero, that's fantastic, but that's not typically what we expect post-operatively. So just making sure people are comfortable and familiar, and really having that discussion of, you can take this frequently. This you take regularly, standing. This is as needed. So just explaining those different things, because this is our profession, but even if one of us is a patient, it's a very different thing when it's your own body. So intellectually you might understand it, but really kind of stepping back and making sure that the day-to-day and the hour-by-hour people truly understand how to take care of themselves, or the families can provide that care, especially with the pediatric population. But so oral medications, people need to be mobilizing, up and moving about. They don't need to be, doing 5K. We don't want them doing a 5K. But really, they need to be able to be up and moving around. You heal better when you move. We want to make sure that they're passing gas, something as simple as that people are often amazed at the conversations that are had at the bedside. It's important. You don't need to have a bowel movement necessarily, but definitely passing gas, moving air through your bowels. That's something that we keep an eye on. So we will ask a lot of those questions that surprise some people. And really just that their pain is tolerable on the medications that they're taking by mouth, so that we continue those same medications on discharge, on that transition. We don't stop things and send you home. We typically continue what you've required. Depending on some of the specifics of the surgery that Dr. Greenfield has done, some people end up on a steroid, some people end up on a non-steroidal anti-inflammatory, depending on some of the, again, the specific intraoperative things. So those are also important things to think of. Some patients tolerate those medications better than others. Sometimes we have to adjust the frequency at which we decrease the dose, or the speed at which we decrease, because steroids they're great for inflammation and for preventative measures, which is the purpose we use them after Chiari. But, they do all have side effects. Every medication has a good and a bad with it. So understanding and describing that, I think if people know what to expect, they're much better able to handle it and either verbalize that it's intolerable, or, this is what they're experiencing and how can we help adjust that, so that then Amanda's job is easier. Any outliers to kind of the protocol, if you will, communicating that to her. We had to change this medication. We had to order this lab, just different things. So that, because we all deal with a lot of patients, so we don't automatically know everything about that person that was done. So we need to communicate with each other for that transition to be seamless. And reciprocally, Amanda or the outpatient team letting us know things. This patient's coming in and has X, Y, or Z. We need to be aware of that. It's very helpful, and it just helps make it smoother for the patient and their family, ultimately.
That's great. It's great. I think you kind of led into what I was thinking, which is now a little bit transitioning into some of the longitudinal care, and you illuminated some of the, the communication that goes on between the outpatient and inpatient teams about outcomes and expectations. But I'd love to open it to anyone about either, kind of common follow-up visits after a surgery, maybe how we make adjustments to symptom modifiers when we plan on revision surgeries. Anyone that kind of wants to contribute to some aftercare and longitudinal care.
Yeah, I think I can start just to echo Beth. When we think about Chiari surgery, we think about head and neck pain post-op, but it's really important to think about what other pains can be caused. So constipation can cause abdominal pain. Increased pressure from constipation can cause head pain, right? So how do we manage all of their pains as a whole? Same with nausea. Nausea is not necessarily pain, but nausea can cause emesis or vomiting, which increases the intracranial pressure, which can put a stress on the surgical site. So how do we manage all of their symptoms to really help minimize pain as a whole? What I love about our discharge team is that they think about all of these things, right? So we're not just focused on pain medication. All of our patients are sent home on a bowel regimen. They are given anti-nausea medication if needed. And so the patients really are prepared to go home in full, not just on a pain perspective, but from other organ systems that can essentially cause pain, which is really important. A lot of times I get the patients, maybe they've passed gas, as Beth said, but they're pretty constipated, but they already have the tools. For me, it's just tweaking how they're utilizing those tools. I'm not really introducing anything, which is great. So everything is very linear. The patients aren't necessarily getting anything new. It's just a continuation of what they know, what's in their discharge instructions, what they've heard. And I'm just reiterating, which is really nice. To go back to your original question of how do we know when we're ready for revision surgery, I at least like to get over the first hump of the immediate post-op period before we start talking about what got better, what didn't, right? I know that post-op you're going to have pain, and I need that acute post-op inflammation to go down, and really giving the patient a fair trial to see how surgery did affect their symptoms before jumping back into revision discussion. So like I said, I talk to the patients a day after they're discharged. They are in touch with me every step of the way. They can call me, they can email me, they can MyChart me. We do a 2-week post-op follow-up visit approximately. It's a little bit different for our out-of-state patients or out-of-country patients, but for the most part, we do a 2-week check-in, whether that's virtual or in person. So that gives me another a marker to know how the patients are doing and how I can tailor resources or pain medications or physical therapy as needed. And then from that visit, our next check-in is at a 3-month post-op check-in with an MRI. So that gives us a visual to correlate with how the patient is feeling, right? And at that point, if they're not feeling well, it's a discussion of, well, what can we change? What can we add, right? Again, not necessarily jumping into a revision discussion, but again, exhausting conservative measures because surgery is a big decision, especially if they want to consider it for a second time.
I don't have much to add to that, Amanda. That was really comprehensive. I mean, yeah, the revision part of this is, that's a real small piece of the puzzle here. That's usually, at least a year out from recovery. And, for patients in whom we're thinking about doing a second surgery, it's usually in a way that's been broached before the first surgery, i.e., we're going to be a little bit more conservative here because of these risk factors, because of your risk tolerance, because of your comorbidities. And if we don't, get the result that we want, we can always do more. in the Chiari world, doing too much is often way worse. And so, I think the thing that we do quite well is have that big picture conversation up front, and the decision to do something less aggressive is in the context of, everyone's input and expectations. And even with that, the need for revision surgery is quite low. So, it's much more about recovering from the surgery and figuring out where has the patient plateaued. And it's usually by 3 months, we have a pretty good sense of where they are. They'll continue to recover, but I would say, 75 or 80% of the recovery is done in those first 3 months, which is a deliberate reason why we wait that period of time to see them and get the scan, because that's a really good benchmark for us to know how they're doing. Yeah, I think if you take all this into a whole, and to, if anyone's watching this and listen, to Dr. Bustillo and Beth and Amanda and myself talking about this, I think, I listen to it with a lot of pride, because this program is, grown tremendously. And, one thing that we've done is we've adapted and we've changed, and, we listen to our patients, and we look at the literature, and we change our protocols, and we change our techniques based on, I think, best practices. And I think that the idea that, if you choose to come to me for surgery, it's not just, the provider that you're seeing in the office that's taking care of you. And I think sometimes that gets lost a little bit, when patients are doctor hopping and they're, looking around, they're like, this guy or that guy, I like her, I like him. It's really a lost perspective that, it may be more important who's taking care of you in the operating room. It may be more important who's taking care of you in the ICU that first night. It's not all about the surgeon. It's a big part of it, and we're the face of the program for sure. But the fact that we've built these teams and built these expertise is something that I'm just as proud of, because I think they contribute to the outcomes, sometimes, in many folds more ways than my surgery does. And so I think I don't want to overstate, any of this, but I think altogether it's a big puzzle, and, having all these pieces in place is, just, incredibly important. So for people who are trying to figure out what to do, should I have surgery? Should I not have surgery? Where should I go? This is not a commercial for us. This is a commercial for find a program where there's comprehensive care, where there's a program where people understand this disease, where that the care is going to be, preoperative, intraoperative, and postoperative. And I think if you find that, collaborative nature wherever you are, I think your outcomes are destined to be good, because it's about communication and it's about caring. And I think we do it really well. And there are some other places in the country, obviously, that do it fantastically well, just as well as we do. But I think this gives us a framework, and gives patients who are watching this a framework for those are the types of things you should be looking for, just as much as, whether or not you like the surgeon on that first visit. There's so much more to it. Any other final closing comments from any of the participants here? You guys have been so gracious with your time, and loved hearing all of your perspectives. Not that often that we're all in the same Zoom together. Actually, we all have such siloed parts of our lives, except Maria and I, of course, in the OR.
Yeah.
I was going to say that was just it was so amazing, I think, to hear from just what a collaborative team you all have. And I can hopefully speak for anyone, who listens to this, and saying that anyone who is, being treated by your team is just so lucky. And I hope ultimately everyone has access to a service like this, whether it's Cornell or not. But I'm really blown away by what you all have shared, and I can't express my gratitude enough.
Wonderful. It was our pleasure to be here.
Yeah, it was a pleasure. Thank you for having me.